Yeah, live, please.
Thank you very much. Good evening, everyone. It is my privilege to welcome our esteemed chairperson, respected panelists, and distinguished speaker to today's postgraduate teaching session on Beyond the Formula, Biometry, and IOL power calculation in normal and complex conditions. We are honored to have such an experienced and accomplished faculty with us whose insights and clinical expertise continue to shape the way we practice modern ophthalmology. Today's discussion focuses on a topic which lies at the very heart of a successful cataract and refractive outcome, the intraocular lens power calculation, both in normal and complex eyes. And as we all know, achieving optimal refractive results is no longer a luxury but an expectation, and mastering the nuances of biometry and formula selection is essential for every ophthalmologist. And I'm pretty confident that this session will not only strengthen our fundamental understanding of the topic, but also provide practical strategies for managing challenging scenarios in day-to-day practice. So without further ado, I would now like to welcome our esteemed faculty. Our chairperson for the day is Dr. Varun Gupta, sir. Sir is the CMD of Gupta Eye Hospital and is situated at Panchkula. Sir is a prolific surgeon and teacher. He is an alumna of GMC Patiala of the 1979 admission batch, and he has done his MS from PGIMER Chandigarh and is presently president of Haryana Ophthalmic Society. He is also a member of Eye Research Foundation, PGIMER Chandigarh, and an ex-president, Academy of Panchkula Ophthalmologists. Welcome to this session, sir. We look forward to learning more from you.
Right.
Our co-chair for the day is Dr. Neeraj Sharma, sir. Sir is Professor and Head, Department of Ophthalmology, SGT University, Gurgaon, Haryana. Sir is a renowned author and teacher with an experience of more than 23 years. He was a fellow cornea, external eye disease and anterior segment microsurgery from Arvind and is a recipient of Asia Cornea Society Educational Grant for Observership at Tokyo Dental College, Japan. He's also a recipient of Tata Trust Grant for 1 month observership at Villa Igia Hospital, Forlì, Italy, and is a recipient of ICSSR sponsored research project. Welcome to this session, sir. Our speaker for the day is Dr. Ankit Vinayak. Dr. Ankit is the medical director at Agarwal's Eye Hospital in Gurgaon, Haryana. He's a prolific cataract surgeon who has served as medical director, cataract services, IQ Eye Hospital, and is currently the clinical lead for Dr. Agarwal's Eye Hospital in Gurgaon. And he has given multiple live surgical demonstrations in state level and national level conferences, and he has trained many clinicians in skills of cataract and refractive surgery across India and Africa. Welcome, Dr. Ankit. Our esteemed panelists for the day are Dr. Vishal Arora. Sir is Head of Ophthalmology, Artemis Hospital, situated in Gurgaon, Haryana. He's a prolific cataract surgeon who's an alumna of All India Institute, New Delhi, PGIMS Rohtak, and Narayana Nethralaya, Bangalore. He established the first dedicated dry eye clinic in Haryana and NCR. He's the ex-president, Gurgaon Ophthalmological Society, and is the founder, Arrow Health Eye and Multispeciality Clinics, and is the faculty at AIOC, ESCRS, WOC, AAO, and DUSS. Welcome to this session, sir. Dr. Deepa Gupta is the next panelist. Ma'am is the director, Satwik Eye Care, and is situated in Gurgaon, Haryana, and is an experienced cataract surgeon and cornea specialist who has served as medical director, cornea and refractive services at Lal 2020 Eye Care. She is an active participant with over 100 presentations at various national and international conferences and panel discussions to her credit. She's an active member of various societies such as GOS, HOS, DOS, AIOS, Caracon, and WOS. She has also presented her work in AAO, ASCRS, and ESCRS multiple times. Welcome, ma'am. We have Dr. Neha Adlakha. Welcome to this session, ma'am. Ma'am is Associate Professor, SHKM, GMC Mewat, and is situated in Mewat, Haryana. She's an experienced teacher and cornea specialist who has over 10 years of teaching experience. She has over 25 publications in national and national index journals and has presented free papers, posters, and surgical videos in international, national, and state level conferences, and has been the invited faculty at national and state conferences as well. She has been the mentor in various SSTC courses and workshops and has received Young Ophthalmology Teacher of India Award in 2024. She has also authored various textbooks for UG and PG students. Welcome to this session, ma'am. We also have our very own Dr. Rajan Gupta, sir. Sir is the director, Rajan Eye, Heart and Laser Center based in Tohana, and he currently serves as General Secretary of Haryana Ophthalmic Society and has previously held the role of Treasurer for the Society. And the convener for this session, Dr. Inder Mohan Rustagi, sir, who is professor and head of WCMS, situated in both Jhajjar and Gurgaon. Sir is an ophthalmologist and eye surgeon based in Gurgaon. He's a teacher and leader in ophthalmology with more than 28 years of experience and is a convener for these PG classes and chairperson scientific committee, HOS. I will now stop here. I'll hand over the podium to Dr. Ankit Vinayak and look forward to learning from him. 。
So So good evening, everyone, and thank you, Dr. Call, for such a wonderful introduction. And I'm just sharing my screen. Just let me know if uh, everyone is able to see. So is my screen visible?
Yes, yes.
Yes, it
Okay.
is, Ankit.
Okay, so today I'll be speaking on a very, very relevant topic, relevant to each one of us, all our colleagues, and more importantly, all the students, which is beyond the formula, which includes biometry and IL power calculation. So, ma'am has already introduced me. I'm Dr. Ankit Vinayak, and I'm leading Dr. Agarwal's Eye Hospital in Gurugram, Haryana as medical director with almost 15 years of experience and many thousand surgeries included in that experience. I would be making a small attempt to share my experience with each one out there. So, moving on. So many
Dr.
times.
Ankit, can I just request you to make it in a slideshow mode, please?
Okay. Is it fine now?
Perfect. Thank you.
Okay. So even a well done surgery, with a perfect rexis centered around the visual axis, with the IOL sitting in the bag and a perfect pupillary with a perfect overhang of the anterior rexis margin, perfect incisions. A perfect surgery can also many times lead to a dissatisfied patient. So even after everything being perfect, where are we going wrong? So the most important source of patient dissatisfaction post a cataract surgery is a poor choice of IOL. So that is very, very important, and that would be our focus in this session. So just starting on with why IOL power calculation is so important. Even a perfectly done surgery can lead to a lot of dissatisfaction if the power of the IOL implanted is not accurate. Cataract surgery is no longer a rehabilitative surgery like it used to be, but a full-fledged refractive surgery. Sometimes unrealistic expectations are set, by us, by our competition, by all the corporate chains in the form of marketing and all the other things. So we need to remember that the only thing that stands between us and a standard and a satisfied patient experience is proper knowledge of IOL power calculation. And how do we crack this? So this is the simple formula, for this entire session, and we'll be using this formula. So IOL power equals to the biometry, which helps us calculate the axial length, plus the keratometry, which helps us determine the proper K values, plus the correct choice of formulae, and there are special ingredients which will give that wow to our patients. Let us see each one of these ingredients one by one. So axial length matters. It is the most critical variable in all IOL power calculation. Majority of the formulas, in fact, each and every formula right from the very beginning uses axial length. We all know by now that 1 mm of error in calculation of axial length can almost lead to a refractive surprise of 2.5 to 3 diopters. These days, ultrasound is less preferred mode of axial length measurement in view of its low accuracy and high user dependence. Applanation is a strict no in modern day biometry. If required, immersion is still acceptable and comparable to an extent to optical measurements. But applanation is a very strict no in today's age and time. I'm sorry, just give me one moment. Okay, so sorry. So moving on, so these are the traditional instrumentations or equipments which help us calculate the axial length, starting from the ultrasound, A scan machines, moving on to the IL Master 500, moving on to the Lens Star, and the most modern days IOL Master 700 and Argus machines. So we have come a long way when it comes to measurement of axial length. And in this journey, we have evolved by leaps and bounds in our accuracy when it comes to axial length. So let us see each and every source of axial length calculation and let us compare them. So ultrasound machines were the starting point of calculation of axial length. The end point of measurement used to be the internal limiting membrane. Error rate was very high. Accuracy was poor, as we see in this chart. And the only place in modern day cataract surgery where I see a role for ultrasound based A-scan machine is in very dense white cataract, in mature cataract, where each and every other machine fails us. Now coming to the partial coherence interferometry machines like IOL Master 500, all the machines here on, measures the axial length till the RPE layer, and this again has low mean axial length error, and acquisition success rate is very good. It is very user friendly, but again it fails us big time when it comes to calculation of axial length in dense cataract, and the success rate is very poor as the density of cataract increases. Uh, Moving on to the optical low coherence reflectometer machines like Lenstar. Now, these are very good machines and gives us very variable data points, which helps us in refining the IOL power calculation. And also, they are very convenient. Accuracy is also very good, almost greater than 90%. And the most modern day swept force OCT machines like IL Master 700 and Argos are the gold standard when it comes to the axial length measurements. It gives excellent accuracy, greater than almost 95%, and it's very suitable when it comes to dense cataract. It has got excellent penetration, excellent success rate, and more importantly, because of features like this, that is the fixation check, wherein we can see the macula and we can see if the patient is fixating properly. Now, this is very important because our calculations are based around the visual axis. Once we are sure that the fixation is checked, it also helps us measure the wide to wide diameters and other critical parameters which go into the modern day formula and helps us give refined IOL powers. There is three-zone keratometry, thus increasing, the accuracy when it comes to the keratometries and K values. Now, keratometry is the next big ingredient. Axial length and keratometry, in a way, are the raw material, for our dish, which is the IOL power calculation. It is another key ingredient when it comes to calculating IR power. So, keratometry is nothing but corneal refractive power, and it directly affects the IOL power. We all know of this fact that one diopter of error when it comes to the K measurement can lead to one diopter refractive error. It is very critical when it comes to toric IOL planning, post-refractive surgeries, and other corneal pathologies. So I just want to check if I'm audible and everything is normal because it's a long, session. And
All okay. Everything
all
is
right.
Perfect. You're perfect.
Perfect. Okay. So starting with our various keratometers, we started our measurements with manual keratometers. They were user dependent and very limited in terms of the data they provided. And we moved on to other various machineries, which gave us a lot of data, but unfortunately did not go to the posterior corneal curvatures, which are very important when it comes to patients who have undergone refractive surgeries previously, or in cases of ectasia, or in cases of very high astigmatism, where posterior curvatures become very relevant. So in this category, I have categorized all those machines which primarily use the anterior curvature data. They include the manual keratometer, the traditional one. They include our ARKs. They include the Placido disc type topographers and IOL Master 500 in this category. Let us go through each one of them and let us also understand their limitation. So manual keratometer, it measures only two meridians. It is based on the Myers reflection, very much operator dependent. It misses irregular astigmatism and it has a small central zone. Automated keratometers, which are integrated as in IOL Master 500 as well, they are faster, repeatable. This is to their advantage, but again, they are limited to the anterior surface. Placido type topographers, they map thousands of points and detect irregular astigmatism and keratoconus. But again, sticking only to anterior surface, there is no data which they provide about the posterior corneal curvatures. Now, Shem flux imaging, when it comes to keratometry, I feel is the gold standard. It makes use of rotating cameras and slit imaging, and it gives us data about anterior and posterior cornea, which we will see further how we can put it to use to refine our biometry, to refine our IOL power calculation, and to satisfy our patient. It also gives us very important data about pachymetry, and it gives us the most important thing, which is very important when it comes to dealing with patients who have undergone prior refractive surgeries in the form of laser corrections. Swept source OCT, which is ILMaster 700 Argus. Again, it is very, very impressive when it comes to their keratometric data. They measure both keratometry and axial length in the same axis. Now, this becomes all the more important. We had discussed earlier about their fixation check, wherein we can see the macula, we can see whether the patient is fixing to the visual axis. That is very, very important. So we get the keratometry which is relevant and based on the visual axis. So that's why this alignment is very, very important, which helps refine our results. It also gives us, total corneal powers and posterior corneal estimation. But the limitation is that these estimations and corneal powers they are still evolving. So conventional keratometers, primarily dealing only with the anterior corneal curvatures, uh, they have their limitations because they assume fixed anterior posterior ratio. They ignore the posterior cornea. So that's why it becomes very tricky in dealing with patients who have undergone prior LASIK or are suffering from keratoconus or high astigmatism. So this is where our conventional machines will fail us. So that's why the importance of machines, which also give us data about the total corneal power and the posterior curvatures. So these were the ingredients of the main dish, that is our IOL power. Now coming, to the main dish, which is the formula. We will use these raw material about which we have studied so far. How one is better than the other, and we will see that how we can utilize all these raw materials into making a good main dish. Now, basically, all the raw data that we get from the axial length calculation and the keratometric values, they are used to predict the effective lens position. Now, this is the central theme of IOL power calculation. Basically, the effective lens position, if it is calculated accurately, you're going to land up with a very, very happy patient. And if we mess up in predicting the effective lens position, a patient is going to have a poor experience. This is the second biggest cause of refractive error, the choice of your formula. First being the measurement errors that we have just spoken about. And evolution when it comes to IL formula means better ELP prediction. Let us see about the various generations of formulas and how they have evolved with time. So we started with regression based formulas. So they were based on basically outcomes of our patient. So, so just a small anecdote, the greatest moment for all cataract surgeon was Dr. Harold implanting the first IOL. But unfortunately, it was not the greatest day, for the patient who underwent that surgery because the patient landed up with a myopic surprise of 20 diopters. So regression-based formulas basically kept on refining with the outcomes. The second evolution when it comes to the formulas were the theoretical formulas, which were optics based. Third was the hybrid formulas, which was a combination of both. And now we are in time of Hill RBF, Kane, LADA super formulas, which are using various pattern, machine learning, and AI, which has come to our rescue. They have also integrated a lot of data when it comes to race, ethnicity, to give us more and more accurate results. So very exciting time when it comes to IOL formulas. Now, this snapshot is something which is very, very important. Although the first, second generation formulas are not very relevant in today's age and time, but I feel that all the juniors and all the students should have a good knowledge of all these formulas, so that at least they should know what to use and when to use. So primarily these days, we don't touch the first and second generation formulas because they were primarily based on axial length and K values only. Okay. And they were very poor when it came to predicting the effective lens position. And they had a poor accuracy to the tune of 50 to 65%. And within zero point 0.5 diopters, if I speak of that, 75 to 85%, which if I give it to you these days, it is not acceptable to any one of us. Now, effective lens position primarily came into picture from the third generation formulas, that is our SRKT, Hoffer Q, and Holiday 1 formula. So, but again, there was limitation because the variables used here were again axial length and keratometry. Okay. Till the time we didn't have the fourth and the fifth generation and the AI based formulas, these were our go-to formulas, and we had made mnemonics also, that for shorter eyes it would be Hoffer Q, for longer eyes SRKT, and for general eyes Holiday 1. So there were various mnemonics during our post graduation days. But again, on the flip side, the accuracy was not very good, around 65 to 75%, and it landed us in plus minus zero point 0.5 diopters in 85 to 90% of cases, which was a good leap coming from the first and second generation formulas. Now, fourth and fifth generation formulas, here things start getting interesting, because here we are using multiple input points, which includes our axial length, K values, anterior chamber depth, lens thickness, white to white, and all of these basically. So that is why more the variables, better the chances of predicting our effective lens position. So that's why our accuracy when it came to landing within plus minus zero point 0.5 diopter of emetropia increased to almost 90%. And these days, the modern day fifth generation formula, I would say for all the postgraduate trainees here or any colleague, you can close your eyes and go for a Barrett Universal 2 formula. It is inbuilt in majority of the modern day biometers. Okay. It uses theoretical and regression hybrid models. It is optimized to almost all kind of eyes, short to long eyes. Again, it uses variable input points. It is excellent across all the axial lengths. Okay. Accuracy is almost 95% or better. When it comes to post LASIK, Barrett True K is a very, very reliable formula. There are other things also which we will discuss during presentation on how we should be approaching these patients who have undergone previous refractive corrections. And the most important, the recent formulas, these are basically online available formulas, which are the Hill RBF, Lada Super Formula, Kane Formula. Basically, it uses a very, very machine learning and pattern recognition approach. It learns from all the data available to it, and it has multiple variables, which helps us predict the outcome much better. It is excellent in almost all kind of eyes, but there is one limitation. Whenever there are values beyond the two standard deviation, be it the axial length or be it the keratometric values, these formulas are redundant, because we won't be able to make any entry onto the online calculators. So I think it is still evolving. Once it collates more data from the shorter and the longer eyes, we would see that range going up from two standard deviation to include a lot more eyes. But again, very, very exciting times when it comes to formulas. My general suggestion to all colleagues and to all juniors is to make use of multiple formula. So generally, I will just explain what I do in my general regular practice. I use a fifth generation formula, which is Barrett Universal 2. It is my go-to formula, and I cross check it with a AI kind of a formula, like a Lada super formula, which is available free of cost, or a Hill RBF formula. So these formulas are available free of cost online. It requires you to enter, your axial length, which is optically calculated, your K values, your anterior chamber depth, in some formulas, your wide to wide and your lens thickness, and the optical A constant. So these are the input points for any kind of online calculator. Even if you have a older machine like an IL Master 500 or any kind of older optical biometer, which is not integrated with the latest fifth generation formula, you can still use the raw data, go to an online calculator and make use of refined results, of all these formulas. So it is not necessary for everyone to upgrade their machine, thanks to all these online calculators. Now, I'm hoping that, we've had a good understanding of the, formula. So moving ahead from here, now this is very, very important that modern cataract surgery is no longer about removing the lens. It is about predicting where the next one will sit. Now, this is make or break. This will either lead to a satisfied or a dissatisfied patient. So that's why this talk that we are having today becomes all the more relevant. Now we have seen the raw material which goes into our dish of calculating our formula. We have seen how the main dish is prepared. Now moving on to the special ingredients. These are the tadka, these are the garnishing, which will make our dish truly mesmerizing and give that additional wow effect to our patient. So, what I generally do in my practice is make use of Pentacam to refine my results. It gives me higher order aberrations. I will just show that how I use this data, and it also gives me a very, very accurate keratometric data. Becomes all the more relevant when it comes to treating a patient who has undergone a previous laser vision correction. I make use of holiday EKR reports, which I'll be showing in subsequent slide. And dry eye evaluation is very, very important. If you see a patient of dry eye, it's very important that you treat the dryness and you repeat the biometry multiple times. It is very important that you treat that mebomitis. Put that patient for a couple of weeks of therapy for dryness and mebomitis and repeat your IL masters or repeat your biometry scans, you will get much refined keratometric results after you have treated the dryness. And many a times, you would be treating a wrong keratometric astigmatism if you have not treated the dry eyes, and you will land up in refractive surprises. So these two are the special ingredients. There are a lot more like eye trace and a lot of other things, but I feel that they are out of bound for a regular practice or to a normal practitioner. It's almost not available. It is good for institutional practices, but to regular practitioners, I think it is very much out of bound because of cost limitations. Now, it's very important to understand the concept of higher order aberration if you want a satisfied patient. So, when it comes to treating cataract, these are the two main higher order aberration that concerns our patient. One is spherical aberration. So, spherical aberration is basically an imbalance of keratometric refractive power between the central and the peripheral cornea in the visual axis. And the second most important higher order aberration is the comma aberration. It is an imbalance of keratometric power either vertically or horizontally with respect to the center of the visual axis. Now, all these higher order aberrations as a standard are calculated in the 6 millimeter zone. So when I refer to higher order aberrations, I am referring to the 6 millimeter zone. So this is a uniform standard. Now let us see, how we can refine our surgery or surgical or IOL power selection, with the help of a Pentacam report. Now here we see that almost a regular kind of a cornea with a regular astigmatism, regular thickness, and a very, very regular Gulf-Franks ratio. Also, the total higher order aberrations are less than zero point 0.5. It is 0.406 micron. Looks a very, very safe cornea to proceed, with any kind of IOL that the patient chooses for his eye. Now, this is the EKR distribution. This is the keratometric value distribution in this patient. When you see a sharp line here. That means it is a very, very regular keratometric distribution, very confined keratometric distribution, and this is going to give you very predictable result. These values of keratometry you can safely use for any kind of formula. This will help you, kind of reach your target endpoint. So this is something that we would want to see ideally. We would want to see a tower here in between. We don't want to see kind of equally distributed keratometric values, because that kind of makes our cornea, with the various k values, very difficult to choose k values, which one to choose from. But here the choice is very, very obvious when it comes to choosing k values. Let's move forward. Now, these are the Zernike's polynomials, which basically helps us understand the higher order aberration that we just discussed. Now, there are three set of rules that I follow when I see this chart. One is the total HOAs should be less than 1 micron, and the N3 and N4, they are relevant to us. The central two charts in N3 is our comma aberrations, the horizontal and vertical comma aberrations, and the N4, the central image here where my cursor is pointed, is our spherical aberration. So as a rule, these aberrations should be less than a third of micron. So that is less than 0.3 micron. For us to safely go ahead, and be sure that the patient is not going to suffer from any kind of higher order aberrations. Because as it is the multifocal and the modern day EDOF kind of lenses, they are going to induce fewer aberrations. We would not want to add on to the already pre-existing corneal aberrations. Now let us see another chart. So here we see some amount of high astigmatism, some amount of red zone when it comes to the axial curves, and even the higher order aberrations are greater than 1. It's very important to tread with caution in such cases. So as we see a very, very distributed K values. When you see such K values, it is very difficult to choose from which K value you should be selecting. And when the choice of selection of K values is difficult.
Close your eyes, close your
Hello? Yeah.
Yes, Dr. Ankit, go on, please.
Yeah. Okay.
Neha, can you please mute yourself, ma'am?
Yeah. So when you see such a distributed K value chart, you need to tread these cases with a lot of caution, because the choice of selection of K value is going to be very, very tricky in such cases. Let's see what does the higher order aberration say. So we see a comma aberration, which is very, very significant. So whenever I see this is the set of rule that I follow in treating any kind of surgery, and it also helps me select the IOL. In such a kind of case, where I see a very high comma aberration, this will be very poorly tolerated by a patient if we implant a trifocal or a EDOF kind of a lens. So it is better. I'm sorry, I'm getting some.
Dr. Neha, can you mute yourself, please, ma'am?
Yeah.
And please carry on.
Yeah. So comma aberrations are very, very poorly tolerated by patient, and it's very important that we stick to a monofocal kind of a lens, or at max an advanced monofocal kind of a lens, but nothing beyond that. So I hope I've been able to cover. Yeah. So with this, I would want to open it
for discussion. Yes,
Yeah,
Dr. Ankit.
yeah, I would want to open it for discussion, and also hear from the seniors and from my colleagues here on what they have to add for the benefit of the larger audience. And yeah, thank you so much.
Thank you, Dr. Ankit. Like you said, for a room full of experienced surgeons, the goal is to move beyond textbook knowledge and spark debate, nuance, and real-world decision making. These are questions that what works best. Those are usually questions without a single correct answer, and that the discussion is there to bring out that personal algorithm failures and refinements. Right. With that, I would open the discussion up, and my first question would be to Dr. Vishal Arora, sir. So, do we have you?
Yeah, tell me.
Yeah. So, sir, my first question would be, so in a routine cataract case with normal biometry, what are those factors you see that make you override your default formula of choice?
So my default formula of choice, as Ankit has rightly pointed out, has been the modern formulas. So I would rather override the formulas in case I see irregularity.
Yeah.
I see a history of a refractive surgery. These are the two cases in which I definitely would like to be more manual rather than depend on the machine. As Ankit had pointed out, modern day equipments, I don't think we are doing topography for everyone. I think you are also not doing topography for everyone when we have the biometry integrated topographies nowadays. I mean, topography integrated biometries nowadays. So, except for the post refractive thing, and then you see that there is a irregular astigmatism. Yes, we do have to take use of multiple machine data and then arrive at a regular calculation. Second, regarding the regression formulas, I still use SRKT actually. I don't know because we have been, 10 years back, SRKT was the gold standard. I mean, and I still do look at SRKT when I'm doing a Barrett's. So I have Argos and Lenstar, so I can do that very easily. It usually mostly gives us almost the same value.
Right,
And
sir.
but nowadays I have seen that for a normal eye, I usually err towards Barrett's. And for a long eye, I am going with SRKT. Long eye is like more than 26.5 for me.
Then 26.5. Okay, okay. Understood. With that, I would like to bring our co-chair for the day into the discussion. Neeraj sir. Hello, Neeraj sir, do we have you?
Yeah, I'm here.
Sir, so, expanding on that discussion, what is your current go-to strategy when you find biometry readings are inconsistent or borderline unreliable?
Most common thing is I ask my postgraduate to repeat. If I'm not still satisfied, I go and do it myself.
Right, sir. Right, sir. So, what happens if it is still inconsistent or borderline unreliable? What is your go-to formula or go-to strategy after you have repeated?
If there is a change of more than 1 millimeter, one diopter, then I look for a reason why there is a discrepancy in the reading. I look for a reason. If I can, I don't have any access to IL master or pentacam, so we are using ultrasound. Maybe I'll go in for immersion. So that's it. That is what we are doing.
Right, sir. Right, sir. So, coming to Dr. Deepa, ma'am, so we're just continuing with this discussion only. So I just want to understand, like when you have these kinds of, hello, am I audible, Deepa ma'am?
Yeah, you are audible.
Yeah.
So what I would like to add one or two points were that first of all we have to make sure the head position of the patient is absolutely fine, because even that error can lead to, especially when you are putting toric IOLs, that can very much lead to erroneous. That has happened with me in fact once. And we ended up putting a toric IOL of 3 diopters, and patient actually did not need it, and then I explanted it and replaced it. So that point should not be missed. And second thing is very important to compare it with the other eye. You can have IL master, immersion, whatever technique you are doing with. It is very important to keep the other eye as well in mind, whether the readings are comparable, or probably a previous history of disparity between the two eyes, or a power difference between the two eyes. And so having a overall look is very important. And plus, if you do have a swept source, like if you do have IL Master 700, it is imperative to look at foveal pit as well. Because
Yes.
it clearly shows the foveal pit, and that really helps in, looking whether the patient is fixated properly or not. So these 2-3 things, if we do, there, the chances of having an erroneous kind of good, and especially all this comes when, apart from this routine biometry, the second point definitely comes when we are planning a toric IOL. So I'll say in person planning toric, yes, we have to see 2-3 readings, as Dr. Ankit kind of really elaborated on that, which was very nicely put, that whenever a patient is having an irregular astigmatism, the EKR value is going to have a very broad curve, and so that itself explains the high comma aberration. So it's not won't be a good choice to put a toric IOL in such cases. So whenever we are putting torics, yes, we should do 2-3 readings, maybe from your auto keratometer as well as lens star, or maybe pentacam. So we should kind of keep, if all the three are very near to each other, then only we should plan a toric. Otherwise, we might as well just put a advanced monofocal IOL. I mean,
So,
or
so just to
multifocal.
add
Yes.
to what Dr. Deepa just mentioned, the axis becomes very, very critical, very important as the magnitude of astigmatism increases.
Correct.
So as the difference in your K value increases, the axis become very, very important. And if you go wrong with the axis, then your patient is never going to be satisfied. So as Dr. Deepa correctly pointed out, it's very, very imperative if you have a
Yeah, so that
higher.
has to be comparable. You're doing this.
Yeah, so it's very, very imperative that if you have a high astigmatism, high difference in K value, that you get your axis correct. And you should go on to more than one, more than two, sometimes three machines, whatever machine that you have to your disposal, to kind of check that axis.
And recheck.
Be it a pentacam, be it a topographer, be it just a simple ARK or an IOL master, and you need to collate the axis. It needs to be within 5 degrees of each other, so that is very, very important, imperative, especially dealing with the higher magnitude astigmatism.
Right, right. So with that, I'd like to bring Dr. Neha, ma'am, into the discussion. Dr. Neha, are you there, ma'am?
Unmute yourself.
Uh, ma'am, you're muted.
Yes, ma'am, please.
So has your preferred IOL calculation formula changed in the last 2 to 3 years? Or
Ma'am, in most of the cases, we use Barrett these days,
okay,
except in cases which are with like long eyes, like more than 26, 27 millimeters axial length. In those, generally we go for SRK-T, but mostly we use Barrett only. We have IOL Master in our setup. So mostly we use Barrett.
right, ma'am. Right, ma'am. So again, coming back to Neeraj sir. Sir, in long or short eyes, do you prefer sticking to one trusted formula, or do you want to cross-check multiple formulas? And if there are differences, how do you reconcile them in your practice?
Most thing is you should stick to one formula which works best for you. But checking again, checking and I don't agree with checking and going in for a assumption, or by putting an IOL just on an assumption. I suggest you should use one formula which works best for you.
Right. Dr. Vishal,
Maybe,
same
but you should
question,
use
sir.
different formula for a axial length which is more than 25 or 24 millimeter, and for shorter eyeballs also.
So what are your go-to formulas for longer or shorter eyes, sir?
Hopper Q.
Okay. Both for long as well as short eyes, sir, you like to use Hoffer Q is?
Shorter eyeballs, I have not seen many eyeballs with axial length less than maybe 22. I don't have any much experience. I can't tell you which formula I will use. Maybe when I come across a shorter eyeball, I will let you know the formula I will use.
Right. So Dr. Vishal, sir, same question to you. Like you said, for longer eyes, you trust SRKT more. So what happens to the shorter ones?
So Hopper and Barrett's have been actually if you go and look at both the output, both work same actually. So it's a longer eye, more than 26.5, which is
When you stick with
very
SRKT,
rare.
like you said.
I see the difference actually. So that's where I actually tend to go to regression only,
Right.
the Barrett's too.
Right. So, and what about post-refractive surgery eyes? Do you rely more on history-based methods, or do you rely more on pentacam only? So do you have a
It's
pentacam
the
in your
multiple, yeah, I have
Okay.
pentacam. So obviously the EKR matters, the value does matter. And Ankit had shown a very good slide where the distribution of the K on the cornea, it matters. The wider it is, the worse your outcome can be. So to guess. So in that case, I think I definitely go to the ACRS calculator, do the multiple. So if I have a history, then I get one different output. If I don't have a history, I do only pentacam and then put the biometry data, then I get a different output. And on the basis of that, I can go to an average where what I think. And that's how I usually do. But actually, I've seen over a period of time, no history method works good, very good. So it's not a matter of, unless it's an RK where you have to go to the RK specifically, where you definitely have to rely. And RK, I don't know whether Ankit in post RK, what are you doing right now? You're
So,
sticking with the
sir,
SKRS or you are doing the Argos? Wala?
okay, sir. So, my protocol for RK is pretty simple. If I see a RK with 8 or less cuts, well epithelialized cuts, not deep, not angry looking, 8 or less, I go in with the normal formulas. I go in with the Barrett's True K or a Barrett's Universal 2. They are pretty safe. The challenge comes when you see deeper cuts, you see angry looking cuts, you see 16 or more cuts. Those are the tricky corneas when it comes to RK. And there, your pentacam, true net power, true corneal refractive power, all these, data points come in very handy. And I use Ascaris online calculator very frequently when dealing with post myopic LASIK or an RK. So it throws in multiple data points. But most commonly, I use a Barrett True K in dealing with post-refractive patients. I stick to EKR values. I do the EKR holiday EKR chart. And another thing is Higgins L myopic is something which still throws up very accurate data. That is another data point that I go to, I refer to, although it is slightly, people consider it a bit outdated, but I have seen it work fantastically. So Higgins L has two set of equation like formulas. One is myopic for myopic LASIK and hyperopic. So we need to select the myopic if the patient has undergone a myopic LASIK. So this is my general protocol when it comes to that. Another point that I could not cover in the slides for the want of time is the value of A constant. Now this A constant is constantly evolving, so all the formulas, they use something known as lens factor, especially the Barrett's Universal 2 and the fifth generation kind of formulas. They use something called as lens factor. And now this lens factor is constantly evolving. Now people using the older machines will not have the evolved lens factor. So it becomes very important for them to put the raw data in the online calculator, because the online calculator are calibrated according to the latest lens factor. The newer machine, it's very important to undergo software updates, because as soon as a machine is updated and connected to net, that is when the lens factor in the machine also gets updated. So this A constant is another very critical piece in the puzzle when it comes to IL formulas. This is something that can have a detailed discussion in itself. For the sake of keeping this session simple, I have not included it, and also for the want of time.
Right. So, Dr. Deepa, another question to you, ma'am. Coming to this is one of my favorite parts of asking questions, because I can ask about corneal surgeries as well. So, how do you approach IOL power in combined procedures, like when you're doing a DSEC or a DMEC with cataract surgery?
Mostly it's the other eye that we take. It's the other eye, or maybe use a standard keratometry and do an immersion. I mean, it's as simple as that. Because so if it's not dense, not that dense a opacity, then I prefer to do a phaco. But still, whatever, for phaco first and maybe a PK later. But still, even in that case, one cannot be that much accurate, and basically rely on the simple formulas and just do a simple immersion. And if the other eye is normal, which
And we
is
can
also a rarity, which
Right.
is also a rarity actually, because invariably that will also have some of the other pathology.
correct.
So in case that is normal, then we can do an IL master or something, but it's mostly immersion that we take.
Right, ma'am.
And yes, RKIs, I've done quite a lot of such cases. So I'll say that what I could finally conclude was that most of them, they do have some amount of irregularity,
Right.
irregular astigmatism. So we have to be very, very careful in putting torics in such cases, and definitely no to multifocals. So this much I would, so whatever IOL formula we may use, their refraction can even change from, time to time of the day. This refraction can be different in morning and evening as well. So it's always the approximation, the best approximation that we can put.
Right.
And exact thing, of course, I mean, I don't think we can aim at reaching the exact emetropia, but yes, most of them are very happy because their plus power reduces. We should aim at doing that. I think maybe overcorrect a bit if possible. Like if
Right.
it's coming, like if what we used to do, like what I used to do was do in both lens star as well as IL master as well as immersion, whichever gives the highest value in post RK. So then we used to take. So immersion, we usually add +3. I'm sure you must also be doing the same. We
Yes.
add up to 6 cuts. We do, +3, and then
Yes, ma'am.
up to 12. That was the conventional thing that we all used to do. So whichever is higher value, that we tend to take that.
Yes, ma'am.
Yeah, that is what I would say.
So Dr. Ankit, Dr. Neeraj has wanted to ask this question. You can
Yes.
comment on the use of IOL master in corneal opacity and comparison of immersion ultrasound biometry.
Okay, so IOL Master again, IOL Master 700, which uses a longer wavelength. It is something that penetrates through any kind of opacity, be it a corneal opacity or be it a dense cataract, will throw up a very, very reliable value. If it's a significant corneal opacity, I doubt if IL Master 500 will be able to deal with it because it uses a shorter wavelength of 780 nanometers. So it is something that will not be able to help us much. IL Master 700 works wonderfully well, even with corneal opacities.
Right, sir. Right, sir. I hope that answers Neeraj sir's question. Coming to Dr. Neha, ma'am, one more question to you, please. And then I'll ask Varun sir for his final comments. Dr. Neha?
Yes, ma'am.
Yeah, so what is the one small change in your planning or your biometry which has improved, which you feel has improved outcomes significantly? Is there anything that you would like to tell the postgraduate students or the practitioners?
Can you please repeat?
Ma'am, am I audible to you?
Hello.
Yeah, am I audible,
Yes,
ma'am?
ma'am. Can you please repeat?
Yeah, so is there some small change in the
Yes,
planning
ma'am. Yes,
or
please.
biometry which has significantly improved your outcomes that you would like to point out to the postgraduate students or to the general practitioners who are just starting their IOL practice?
Basically, ma'am, earlier we were not using Barrett. But once we have started using Barrett, the reduced a lot basically. Basically normalized Barrett's is the gold standard which should be used in like most of the cases with the normal axial length basically.
Right, ma'am. Right, ma'am. Rajan sir, one question to you, please. You've been a silent observer of the class so far. So, sir,
Mute.
unmute, please, sir.
अनम्यूट कर लो भाई साहब हो गया भाई हो गया
Yeah. Sir,
Hmm.
so, sir,
Yeah, so, yeah.
you've heard the whole thing, right?
Yeah.
Do you think fully automated or AI-driven IOL selection is going to replace surgeon judgment in the near future?
fully automated
Do you think fully automated or AI-driven IOL selection is going to replace surgeon
Yeah,
judgment in the near future?
already basically the IL Master 700 is one of the things which is AI driven basically.
Right.
I even don't see generally what it is what I'm doing. My assistant tells which IL to be put. They look into the calculations of the IL Master formula is already pre-fed, and 99.9% times they are accurate.
Right.
According to the toric placements, according to the excellent biometry, I think Almasa 7 is one of the, and Argos even, it's a flawless machines. You can trust them blindly. I had only once had refractive surprise in my OT when I operated two patients simultaneously, and one had 20 diopters of power and another had 24 diopters of power.
Okay.
And the next day, the patient came for the follow-up. One was hypermetropy for 2 diopters of myopia, another was myopic for -2 diopters. So what had happened, the both patients had the same name, and females of the same ages, and the wrong IL was implanted. The biometry was not wrong, but the assistant was wrong at that time. So you can trust these machines. I think this is also AI driven, and I think the more better machines are coming in future.
Right, sir. So this is one question I actually wanted to ask. What has been your most memorable refractive surprise and how did it change your practice? But Inder sir, can we come to you, sir? So what has been your most memorable refractive surprise? And what kind of change in your practice did it bring about?
See, Dr. Amita, it is fine that we are, driven by the new machines and the people are buying it, corporate practice is coming into it. But still, the 90, I would not say 90, 70 to 80% of the practitioner or the institutions are still using routine biometers, right? And one thing I would advise that contact biometers, they are going to be out and one should not use. At least immersion biometers should be the thing of the choice. For a routine case, whatsoever, at least invest whenever you start your practice, whenever you start your institution or whatsoever you do, at least you should have an immersion biometer. And I think if we can't afford that 40 lakh machine or 50 lakh machine, that is not possible for all of us. In the evening, we were just discussing community of ophthalmology. India is a country of masses, and at least we should have immersion biometer with us. And I think that is the ideal.
Right, sir. Thank you so much for your comments, sir. Closing comments from the chairperson.
So before we close, I would just want to highlight one interesting case, a biometry goof up, because sir just mentioned about contact and immersion. So this was way back when we used to do contact biometry, applanation and immersion both. So while doing applanation and immersion, there is a mode basically. You need to switch the mode, whether it is applanation or whether it is immersion. So I had a refractive surprise of almost 4 diopter because the technician did not change the to immersion mode and it was on applanation mode. So this is very relevant to a lot of people who are using the ultrasound machines, and I would completely agree with Dr. Indermohan Rastogi. And in fact, data shows us that it is almost the when it comes to the quality of data, it is greater than 95% accuracy when compared to an IL master, immersion kind of a biometer. So very relevant even in today's age and time.
Right. I think we agree on that particular point. So, closing comments from the chairperson, please. Varun sir.
Dr. Ankit covered it very well. Rather, the level of the discussion was much higher than the postgraduate level. It was of a PhD level, but still it is very eye-opener for everybody, including us. One thing we missed was silicone oil filled eyes. Silicone oil filled eyes. In ultrasound based biometry, it is very important. In optical, may not be that important. And another formula which I use is Shamas no history formula, and it has given me a very good results. Rest everything was very nicely covered. Congrats to you all.
Thank you very much. Inder sir, closing remarks from you, please.
Yeah. So A really commendable job done by Dr. Ankit, always a champion. And I thank Dr. Varun Gupta for giving us this time on this podium. And of course, Dr. Rajan Gupta, Secretary. And really thankful to Dr. Deepa, Dr. Neha, Dr. Neeraj Sharma, and Vishal. They have done a wonderful job. And I hope this kind of the discussion will really benefit the postgraduate of the Haryana, as well as those who are listening to us. And was very nicely conducted webinar by, especially this, taking this to the high by Dr. Amita.
Yes,
So
sir.
really thankful for this wonderful job, and thanks to Entoured also. So I hope.
Yes, sir. So as we come to the end of this enriching session, I would like to express my sincere gratitude to our esteemed chairperson, co-chairperson, respected panelists, and our speaker for sharing their valuable insights and practical wisdom on IOR power calculation in both normal and complex eyes. Today's discussion, as Dr. Inder Mohan has said, has beautifully highlighted not only the scientific principles, but also the real-world challenges we encounter in achieving optimal refractive outcomes. The clarity and depth of perspective shared will not just help the postgraduate students, but also undoubtedly serve as a guiding light for also our general practitioners who strive to refine their clinical decision making in everyday practice. And with that, we'll conclude today's class. Thank you very much for your enthusiastic participation. It has been an honor to host you all. Thank you so much.
Thank you so much, Amita.
Thank you.
Really.
Thank you.